Welcome back to the deep dive. Today we are tackling, I think, one of the most intricate and frankly variable regions in the entire human body.
We are. We're looking at the anatomical architecture of the gallbladder and the biliary tree. It's basically the body's plumbing system for digestion.
And when we say plumbing, we're really talking about a complex highway of ducts, right?
Exactly. It's a network that collects bile from the liver and gets it down to the duodenum where it's needed. And, we have to split it into two main parts.
Okay.
You've got the intrahepatic system, which is all the tiny stuff hidden inside the liver, and then the extrahepatic system, which is everything outside.
And the main takeaway from our sources today is that this system is, well, it's not standard.
Not at all. If you think anatomy's always by the book, this is the area that will prove you wrong. We're talking about variations in nearly 40% of people.
Which is a huge number when you're a surgeon.
It is. So our mission today is to really help you visualize these structures, understand how they relate to each other, and most importantly, be aware of all those variations.
All right, let's dive in. The star player first. The gallbladder. We know it stores and concentrates bile. What are we looking at?
So picture a small pear-shaped sac, a blind-ending one. And in a living person, our sources say it has a very distinct gray-blue color.
Oh, that's interesting. I guess that helps it stand out.
It really does. In terms of size, it's pretty small. Its resting volume is only about 25 milliliters.
But it can expand.
Oh, yeah. It can stretch to hold up to 50 milliliters, and it concentrates that bile by as much as 10 times. It's very efficient.
And where is it sitting? How do we place it?
It's tucked right under the right lobe of the liver, firmly attached to that inferior surface. Specifically, it sits in a little depression between liver segments 4 and 5.
And if you were trying to find it from the outside?
Its most bulbous part, the fundus, usually lines up deep to the ninth costal cartilage.
Okay, so let's break it down into its 4 regions. You just mentioned the fundus. Why is that specific part so clinically important?
Well, the fundus is that widest, roundest end, and it's the part that often peeks out from under the liver's edge.
So it's the most accessible part.
Exactly. If a doctor suspects something's wrong, like inflammation, that's the spot they're going to palpate to check for tenderness or enlargement.
Makes sense. Moving medially from the fundus, what's next?
You get to the body. The body is the main part, and it's in direct contact with the liver's underside. It's also right up against the duodenum and part of the transverse colon.
So it's in a crowded neighborhood.
Very. Then the body tapers down into the infundibulum, which is sort of the angled funnel-like section.
And that leads to the final piece, the neck. This is where things get critical, isn't it?
This is the exit. The neck connects directly to the cystic duct, which is the only way out for the bile. The cystic artery is also usually found right here.
Okay, now for the quirks, the anatomical curveballs. Let's talk about the Phrygian cap.
Right, so the Phrygian cap is just a benign variant where the fundus is sort of folded back over the body. It doesn't cause any problems. But on an ultrasound, that fold can look exactly like a septum or a wall inside the gallbladder.
So it's a structural optical illusion, basically.
Precisely. It can lead to a lot of unnecessary worry if you don't recognize it for what it is.
Okay, what about something a bit more sinister, Hartmann's pouch?
Yeah, this one is more clinically relevant. It's a little outpouching that can form at the junction of the neck and the body, often from chronic inflammation.
And why does that matter?
Because it's a perfect spot for gallstones to get stuck. It becomes a little trap. And when a stone gets lodged in the neck, that's when you can get serious complications.
It's like a natural catchment basin for trouble.
No.
Are there other rarer variations surgeons need to know about?
Oh, absolutely. They're rare, but you have to be aware of them. Things like duplication, where someone has 2 gallbladders.
Wow.
Or the opposite, agenesis, where there's no gallbladder at all.
Mm.
And sometimes it's just in the wrong place entirely, like on the left side. Imagine preparing for a standard surgery and finding that.
That would completely change the game. All right, so let's trace the bile's journey to the gallbladder, starting deep inside the liver with the intrahepatic biliary tree.
So deep in the liver, it starts with these microscopic ductules. They all merge together, like tiny streams forming bigger rivers.
And those become segmental ducts.
Right. And those segmental ducts eventually come together to form the 2 main pipelines, the right hepatic duct and the left hepatic duct.
How are those 2 different once they leave the liver?
They're quite distinct. The left hepatic duct is longer, more horizontal. The right hepatic duct is much shorter, almost vertical.
And I hear the right side is where all the anatomical drama happens.
It is. The right hepatic duct itself is formed from 2 main branches, an anterior one and a posterior one.
And there's a special curve here, isn't there?
There is. The posterior branch has to sort of hook around the anterior one before they join. This little curve is called Hjortsjö's crook.
And that's not just a fun name, it's a surgical landmark.
It's a critical one. You have to respect that crook during a liver resection, or you risk injuring the duct.
Is there anything on the surface of the liver that can help guide a surgeon?
Yes, thankfully. There's a fairly constant little groove called Rouvier's sulcus. It's a reliable landmark because it often lies directly over the path of that right posterior sectoral duct.
So if you're doing laparoscopic surgery, seeing that sulcus is like finding an X on a treasure map.
Exactly. It tells you where you are and what's lurking just beneath the surface. It prevents you from dissecting blindly.
Okay, this is where it gets wild. Let's talk statistics. What percentage of people actually have that normal textbook duct pattern?
This is the shocking part. Only about 60%.
Wait, 60. So 4 out of every 10 people have a different setup.
That's right, which is why a surgeon can never assume.
So what are the big variants we see in that other 40%?
Well, there's type 2, which is a trifurcation. The right anterior, right posterior, and left ducts all just join at one single point.
So there's no real right hepatic duct.
Correct. Then there's type 3, where one of the right-sided ducts, usually the posterior one, drains into the left hepatic duct.
That's completely counterintuitive.
It's a major hazard. And then type 4 is when a duct drains way too low, joining the common hepatic duct directly. Missing any of these can be catastrophic.
And there are even smaller ducts to worry about, like the subvesical ducts.
Yes, these are tiny little things from segment 5 that can run across the gallbladder fossa. If you don't stick right to the gallbladder wall during a removal, you can snip one.
Leading to a bile leak.
Persistent, really problematic post-op bile leak.
Yeah, the complexity is just astounding. Okay, let's move outside the liver to the extrahepatic tree, starting with the cystic duct.
So the cystic duct is the short tube leaving the gallbladder. It's usually a bit tortuous, meaning it twists and turns on its way to join the main duct system.
And inside it has those mucosal folds, right? The spiral folds of Heister.
Yes. They're like little crescent-shaped shelves inside the duct. The thinking now is that they're not really a valve, but they probably help keep the duct from collapsing on itself.
It's just keeping it open.
Exactly. Preserving patency so bile can flow in and out.
And its junction with the common hepatic duct is another area full of variation.
Hugely variable. It can join too low, or from the front or the back. Sometimes it runs parallel to the main duct for a while, if you don't identify that junction perfectly.
You risk clipping the main bile duct instead.
Which is one of the most feared complications in general surgery.
So once they finally join, we have the bile duct, or the common bile duct.
Right. It's about 6 to 8 centimeters long, and its diameter should really be under 7 millimeters.
And we can break its path down into segments.
We can. First is the supraduodenal segment, which is inside that hepatoduodenal ligament. It's the most surgically accessible part.
Okay.
Then it passes behind the duodenum, that's the retroduodenal segment, and finally the pancreatic segment, which runs in a groove on the back of the pancreas head.
And that leads us to the grand finale, the pancreatico-biliary junction.
This is where it all comes together. The bile duct and the main pancreatic duct join up, usually in a little Y shape, to form a short common channel.
And that little chamber is the hepatopancreatic ampulla, the ampulla viter.
That's the one. And it opens into the duodenum at the major duodenal papilla.
There's a dangerous anomaly here with that channel, though.
A critical one. If that common channel is too long, meaning the ducts join outside the duodenal wall, it's a problem.
Why?
It allows pancreatic juices to flow backwards up into the bile duct. And that reflex is strongly associated with bile duct cysts and a much higher risk of gallbladder cancer later in life.
Wow. So who's the gatekeeper here? What controls this flow?
That would be the sphincter vadi. It's a complex little muscle that wraps around the end of the ducts in the ampulla.
And it does two things, right?
Two crucial things. It controls the forward flow of bile and pancreatic juice, and it prevents stuff from the duodenum from backing up into the ducts.
So what's the signal to open the gates?
It's all about the hormone CCK, or cholecystectomy. When you eat fat, CCK is released.
And it orchestrates a two-part response.
A perfect one. It tells the gallbladder to squeeze hard, and at the exact same moment, it tells the sphincter vadi to relax.
So you get a powerful, well-timed jet of bile right when you need it.
Precisely. It's a beautiful piece of physiology.
Let's shift to the blood supply, the surgeon's point of view, the cystohepatic triangle.
Ah, yes. the critical zone.
Yeah.
It's the space bordered by the cystic duct, the common hepatic duct, and the liver itself. This is where you expect to find the cystic artery.
Usually.
Usually, about 80% of the time, it comes off the right hepatic artery right in that triangle. But the other 20%, it could be anywhere.
And if a surgeon sees a big artery there and just assumes it's the cystic artery,
They could accidentally clip the right hepatic artery itself, which would be devastating for that part of the liver. You have to be absolutely certain.
what about the blood supply to the ducts themselves? Is it robust?
It's a delicate network. And it's not uniform. This is another really important clinical point.
Oh.
The supraduodenal part of the bile duct, that first segment, actually has a poorer blood supply than the rest of it.
Which means it's more vulnerable.
Very vulnerable to ischemic injury. If you dissect too aggressively around it, you can damage its blood supply and cause a nasty scar or a stricture to form later on.
Okay, last piece of the puzzle. Pain. When someone has a gallstone attack, why do they feel it where they do?
The pain signals travel along sympathetic nerves, up through the splanchnic nerves, to the T7 to T9 spinal segments.
And the brain interprets that as pain in the upper right abdomen.
Right, the classic right hypochondriac or epigastric pain.
Yeah.
But because of that nerve pathway, the pain often radiates around to the back.
To the right shoulder blade?
Exactly. That referred pain is a classic sign.
So let's bring it all home with the most common problem, gallstones.
They form in the gallbladder, and when it contracts, a stone can get pushed into that narrow cystic duct. That blockage is what causes that intense pain biliary colic.
And the worst case scenario with a stuck stone is Maritzi syndrome.
Yes. This is when a stone gets impacted in the gallbladder neck, and the inflammation is so bad that the swelling actually squashes the common hepatic duct next to it.
So the main duct is blocked from the outside.
Correct. And that causes jaundice. It's a mechanical obstruction, but the stone isn't even in the main duct. It's a really tricky surgical situation.
So to synthesize this, we've got a system that is just defined by variation. Only 60% of people are normal.
Right. And we've seen all these high-stake zones like the cystohepatic triangle and crucial structures like the poorly supplied supraduodenal bile duct.
And it's all controlled by this elegant hormonal system with CCK and the sphincter of Oddi.
I think the main lesson here is that variability is the rule, not the exception. Knowing about things like Hjortsjö's crook or the folds of Heister isn't just academic. In this area, it's about patient safety.
That is an incredible journey. So let me leave you with one final thought, building on what we've discussed. We know the bile ducts inside the liver depend heavily on the hepatic artery for their blood supply. So, what kind of immediate disaster would a clot, a thrombosis in the hepatic artery cause for those ducts, even if the main portal vein flow to the liver is still perfectly fine? It's a key question in liver transplantation.
An excellent thought. Really ties the anatomy to a major clinical problem.
Thank you so much for joining us for this deep dive into the gallbladder and biliary tree. We hope you feel thoroughly informed.